Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text.
Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels almost like engineering.
Right, it's a very comforting illusion.
Right.
We really crave that binary clarity.
Yeah, exactly. You break your arm, the x-ray shows that jagged white line through the radius, and the doctor just points at the film and says, there it is, that's the problem.
Broken or not broken, infected or sterile, we want the pathology to be visible and, static.
But then you step into the world of hematology. You start looking at the blood, the bone marrow, the immune responses, the coagulation cascades.
And suddenly that x-ray machine is utterly useless.
Exactly. We're looking at a diagnostic landscape that is incredibly murky. It's fluid. It's constantly shifting in real time. You can't just take a snapshot of it.
Because the blood is essentially a liquid organ. It is the absolute definition of diagnostic muddy waters because, every single component is highly reactive.
Oh, for sure. If one protein shifts, it triggers a cascade that alters a dozen other systems. And that dynamic, sometimes chaotic environment is exactly why we are here today. So welcome to this deep dive. If you're listening right now, you are stepping into a profound exploration of biological mysteries.
Consider this an immersive conversational breakdown of the pathophysiology of the blood. Specifically, we're focusing on the material from Chapter 29.
Yeah, we're going to strip away the dense textbook jargon and get down to the actual mechanisms. Our mission today is to figure out the why and the how.
Not just memorizing a list of symptoms for an exam, but genuinely understanding the cascade of events happening inside the patient.
Which is so much more useful.
It is. The overarching philosophy we have to adopt here, really the only way to truly decode pathophysiology, is to relentlessly tie the abnormal back to the normal.
Right, because you can't grasp altered cellular function until you intimately understand what that cell was designed to do in the first place.
Exactly. The sequence is always the same. Normal physiology breaks down, leading to altered cellular function.
And then that cellular failure compounds into tissue and organ dysfunction.
Yes, and that organ dysfunction is what finally bubbles up to the surface as the clinical signs and symptoms you see at the bedside. If we connect the underlying mechanism to the physical manifestation, the entire subject comes to life.
Okay, let's unpack this. I want to start with the red blood cells, the core of our oxygen delivery system, and specifically anemia.
A very misunderstood topic.
Oh, totally. Because when the average person hears anemia, they usually just think, I need to eat more spinach. I have low iron. But biologically, it is so much broader and more complex than that. Let's establish a really rigorous baseline definition.
At its foundation, anemia is a reduction in the total number of circulating erythrocytes, the red blood cells, or it's a decrease in the quality or quantity of the hemoglobin contained within those cells.
Okay, so it's about the cells or the stuff inside them.
Right. But the critical distinction here is that we are talking about a true decrease in the red blood cell mass.
Wait, a true decrease as opposed to a fake decrease? How can a blood test show low red blood cells if they aren't actually low?
Well, think about the blood as a mixture of solid cells and liquid plasma. Sometimes a patient might experience an abnormal increase in their blood plasma volume.
Like if they're retaining water.
Exactly.
Yeah.
Perhaps their kidneys are failing and they're retaining massive amounts of fluid. The actual number of red blood cells in their body hasn't changed at all.
Oh, I see. But because they are swimming in so much extra water, the concentration of red blood cells drops.
Precisely. That is called relative hemodilution. The lab report might flag it as anemia based on concentration, but the bone marrow factory is working perfectly.
Makes sense.
True anemia means the factory production is actively failing, the cells are being actively destroyed, or the whole blood is physically leaking out of the cardiovascular system.
That makes perfect sense. The ratio is thrown off by the water, not the cells. And true anemia is incredibly common, right?
Very common. The demographic data shows that an estimated 10 to 15% of the total U.S. population has some form of it.
Wow. And if you look at the elderly, it explodes. Something like 40% of men and 22% of women over the age of 85 are dealing with this.
It's a massive issue in geriatrics.
So if we're trying to figure out which of the dozens of types of anemia a patient has, we can't just guess. We categorize them based on morphology. We look at them under a microscope.
Right. We let the physical architecture of the cell tell us what went wrong in the assembly line. The nomenclature relies heavily on two specific suffixes.
Okay, what's the first one?
The first is alpacitic, which simply refers to the physical size of the cell, measured by the mean corpuscular volume, or MCV.
So if the factory is churning out cells that are way too big, swollen, and clumsy, we call that macrocytic.
Exactly.
If they are tiny and shriveled, that's microcytic. And if they're the perfect size, but there just simply aren't enough of them, they are normocytic.
Spot on. The second suffix is albichromic, referring to the hemoglobin content.
Because hemoglobin is the iron-rich protein that actually carries the oxygen, right?
Yes, and it happens to be what gives red blood cells their brilliant red color. We measure this via the mean corpuscular hemoglobin concentration, the MCHC.
Where?
If the cell is packed with a normal amount of hemoglobin, it's normochromic. If it's starved of hemoglobin, it looks pale and washed out under the microscope. That is hyperchromic.
So putting those puzzle pieces together, if a patient has iron deficiency, meaning they don't have the raw metal needed to build the hemoglobin, the resulting cells are going to be both tiny and pale.
Yes.
Therefore, iron deficiency is a microcytic hypochromic anemia.
A perfect translation of the terminology.
Yeah.
You will also frequently see two other descriptive terms on a pathology report that indicate a chaotic bone marrow environment.
Which are?
Anisocytosis indicates that the red blood cells are assuming wildly various unequal sizes rather than being uniform. And poikilocytosis means they are assuming various abnormal shapes.
Like teardrops, spheres, fragments, that kind of thing?
Exactly. Both indicate the bone marrow is under severe stress and losing its quality control.
But here's the fascinating thing. Whether the cells are giant, tiny, pale, or completely misshapen, the ultimate systemic crisis is identical.
The blood loses its oxygen carrying capacity.
Right. The body is effectively suffocating at the cellular level. This is hypoxemia, leading to tissue hypoxia. And the body does not take suffocation lightly.
Not at all. It triggers a massive systemic panic response across multiple organ systems to try and compensate. Let's trace that panic, starting with the heart and the blood vessels.
The cardiovascular system's response is like a masterclass in short-term survival, prioritizing over long-term stability.
Very well put. When red blood cell mass drops significantly, the total volume of fluid in the blood vessels also drops.
Because there's just less physical stuff in the pipes.
Right. The body's immediate terror is that the vessels will collapse from lack of pressure. To prevent this, interstitial fluid, the water surrounding your tissues, is rapidly pulled into the blood vessels to puff them back up.
Okay, so the body successfully restores the volume by adding water. But that creates a massive mechanical problem. Let me try an analogy here.
Go for it.
Imagine normal, healthy blood full of red cells is like a thick, rich syrup, slowly and steadily moving through a pipe. Now, to keep the pipe full, you've watered down that syrup. It's now the consistency of tap water.
Okay, I see where you're going.
Water doesn't flow like syrup. It flows much faster, and it flows with a lot of turbulent, chaotic splashing.
Yes, the fluid dynamics change entirely. The blood loses its viscosity. Because it's thinner and flows with less resistance, it creates a hyperdynamic circulatory state. The blood is rushing through the system.
And the heart has to keep up with that.
Exactly. Now, pair that thinner blood with the fact that the tissues are screaming for oxygen. The heart realizes, I have less oxygen per drop of blood, so I have to pump these drops much, much faster to deliver the same total amount of oxygen.
So the heart rate spikes. The stroke volume, the amount of blood pushed out with each beat increases. The heart is just pounding.
And because that watery, thin blood is rushing so fast and turbulently through the cardiac valves, it actually creates a sound.
Oh, wow. Is that why severe anemia can cause a heart murmur?
Exactly. You are literally hearing the chaotic fluid dynamics. And if this state persists, it becomes destructive.
Because the heart muscle is working in overdrive, constantly pumping massive volumes of thin fluid day and night.
Over time, the cardiac muscle dilates and stretches. The valves can become insufficient because the heart loses its tight shape.
So ultimately, this relentless hyperdynamic state can lead directly to high-output cardiac failure. The heart literally works itself to death trying to compensate for the lack of red blood cells.
It is brutal, but accurate.
Okay, so while the heart is beating itself to death, what are the kidneys doing to help?
The kidneys are exquisite sensors of blood flow and oxygen tension. When they sense the hypoxia and the shifting blood volume, they activate the renin-angiotensin-aldosterone system.
That's a hormonal cascade, right?
Yes, one that essentially commands the body to aggressively retain salt and water. The kidneys are trying to boost the extracellular fluid volume to keep blood pressure up.
which is incredibly counterproductive. I mean, the heart is already drowning in thin, watery blood, struggling to pump this massive volume, and the kidneys are actively adding more salt and water to the mix.
It really is.
It's like pouring more water into a sinking ship because you think the problem is that the ship isn't heavy enough.
The compensatory mechanisms are blind to each other. But the kidneys do contribute one vital, helpful response. They synthesize and secrete erythropoietin, or EPO.
Yes.
The hormone travels straight to the bone marrow and acts as an emergency alarm, demanding the immediate proliferation and maturation of new red blood cells.
Meanwhile, the lungs are trying to pull in more air. You see an increased rate and depth of breathing.
The patient experiences exertional dyspnea. They get winded just walking to the bathroom.
But there is a hidden microscopic adjustment happening inside the red blood cells themselves that I find absolutely brilliant. It involves a molecule called BPG.
Yes, bisphosphoglycerate. The role of BPG is a beautiful example of molecular adaptation. Normally, hemoglobin holds onto its oxygen molecules quite tightly. It doesn't want to let go until it has to.
But in a state of anemia, the cells ramp up their production of BPG. How does that actually help deliver oxygen?
BPG physically wedges itself into the hemoglobin protein structure.
Oh, interesting.
Yeah, by binding to the hemoglobin, it forces a conformational change. It alters the shape of the protein. This change dramatically decreases hemoglobin's affinity for oxygen.
So when that red blood cell finally reaches a starved tissue bed, the BPG essentially pries the hemoglobin's fingers open, forcing it to release the oxygen payload much more readily than it normally would.
It's a chemical trick to maximize oxygen delivery from a limited supply of carriers.
Incredible. So knowing all this internal chaos, the pounding heart, the shifting fluids, the chemical alterations, what do we actually see when we walk into the patient's room?
The most obvious manifestation of hypoxia is pallor. You look at the skin, the mucous membranes, the lips, the nail beds, the conjunctivae at the eyes.
They become noticeably pale because there simply isn't enough red oxygenated hemoglobin circulating near the surface of the body.
Exactly.
But sometimes they aren't pale, sometimes they are yellow.
Right. If the specific cause of the anemia is hemolysis, the active violent destruction of red blood cells, then massive amounts of heme are dumped into the system.
And heme is broken down into bilirubin.
Yes. If the liver can't process the bilirubin fast enough, it accumulates in the tissues, causing jaundice. So the skin and the sclera of the eyes turn yellow.
And what about fever? A low-grade fever is mentioned, which always makes me think of a bacterial or viral infection. But there's no infection here.
It's a sterile fever. When tissues are severely deprived of oxygen for prolonged periods, they become ischemic.
Ischemic tissue gets damaged, right?
And damaged tissue releases inflammatory pyrogens, fever-inducing chemicals, directly into the bloodstream. The body's thermostat is reset by the tissue's cry for help.
Additionally, depending on the cause, you might see profound neurological symptoms like numbness in the limbs or difficulty walking. But we will explore the exact mechanics of that when we discuss B12 deficiency.
Indeed.
Okay, we have a solid grasp on what anemia is and the desperate lengths the body goes to survive it. Now we need to look at the specific causes. Let's start with the most intuitive one. The blood is simply leaving the body. Acute blood loss.
With post-hemorrhagic anemia, the fundamental issue isn't a factory defect. The bone marrow was making perfect blood right up until the moment of the trauma or the ruptured vessel.
Therefore, the red blood cells that remain inside the patient are completely normal in size and hemoglobin content.
Exactly. Acute blood loss produces a classic normocytic, normochromic anemia.
The danger here isn't just a slow drop in oxygen. It's a catastrophic drop in intravascular volume. It's hypovolemic shock.
And the clinical presentation shifts dramatically depending on exactly how much blood is spilled. The standard classification uses a 70-kilogram male as the baseline.
Let's walk through what a patient looks like as they bleed out, stage by stage.
Class I hemorrhage represents a loss of up to 750 milliliters, which is about 15% of total blood volume. At this stage, the body's compensatory mechanisms handle the loss effortlessly.
So the pulse remains under 100 beats per minute, blood pressure is entirely normal, and urine output is fine.
The patient might seem slightly anxious, but physically they appear stable.
But as they keep bleeding, we enter class 2. That's 750 to 1,500 milliliters, or 15 to 30% of their blood volume gone. Now the cracks start to show.
The heart has to speed up to maintain pressure, so the pulse jumps to between 100 and 120. The systolic blood pressure might hold steady, but the pulse pressure narrows.
Their respiratory rate climbs as they try to pull in more oxygen. And crucially, the kidneys notice the drop in volume.
To conserve water, urine output drops to maybe 20 to 30 milliliters per hour.
Class 3 is the tipping point into severe danger. 1,500 to 2,000 milliliters lost, 30 to 40% of total volume. The compensatory mechanisms fail to maintain equilibrium.
Blood pressure plummets. The pulse races at 120 to 140 beats per minute. Urine output falls to a mere 5 to 15 milliliters an hour.
And because the brain is now actively being starved of blood flow, the patient's mental status deteriorates into severe anxiety and confusion.
Which leads to class 4, massive hemorrhage. Greater than 2,000 milliliters, meaning more than 40% of the body's lifeblood is gone.
The pulse is a faint, rapid flutter over 140. Blood pressure is profoundly low or unreadable.
Urine output is negligible because the kidneys have completely clamped down all arterial flow to themselves to save the brain and heart.
The patient is lethargic, unresponsive, and without immediate aggressive intervention, cardiovascular collapse and death are minutes away.
If the bleeding is stopped and the patient survives the initial trauma, the internal landscape over the next 24 hours is fascinating.
Right. The fluid shifts we discuss pull water into the vessels, resulting in significant hemodilution. The blood becomes very watery.
Simultaneously, the bone marrow senses the systemic emergency and prematurely empties its reserves. It dumps massive amounts of stored neutrophils, a type of white blood cell, into the blood, causing a sudden spike in the white blood cell count.
Platelet counts often surge as well, and the kidneys are flooding the system with erythropoietin, screaming at the marrow to replace the lost red cells.
But the marrow hits a massive bottleneck. You need iron to make hemoglobin. If you have literally bled your body's iron stores out onto the pavement, the marrow is suddenly starved of its primary building block.
The production line stalls. To prevent this and to restore the immediate volume loss, especially in class 3 and 4 hemorrhages, we intervene with intravenous fluids and fresh whole blood or packed red blood cell transfusions.
Now, this brings us to a part of the pathophysiology that genuinely blew my mind.
Oh, I know what you're going to bring up. I read the warnings about blood transfusions and I was completely confused.
It's a bit of a paradox.
Yeah. If I have a trauma patient who has lost 40% of their blood, giving them perfectly cross-matched, stored red blood cells seems like the ultimate unambiguous lifesaver. But the text explicitly cautions that giving a critically ill patient a transfusion could trigger a massive blood clot. How on earth does giving someone much-needed blood cause a deep vein thrombosis? Is the donor blood tainted?
It's not tainted. It's structurally altered by the reality of being stored outside a human body. This is a brilliant example of how microscopic cellular architecture impacts systemic health.
Okay, lay it on me.
Red blood cells in a plastic bag in a refrigerator are not in a state of suspended animation. They are slowly degrading. Over weeks of storage, they undergo severe metabolic and structural impairments.
So they age poorly.
Very poorly. The cell membranes begin to break down, shedding microscopic fragments called microparticles into the fluid. But the most dangerous change involves a specific lipid called phosphatidylserine.
Okay, let's zoom in on that. What is phosphatidylserine and why is it dangerous?
In a healthy circulating red blood cell, the cell membrane is a lipid bilayer, an inner layer and an outer layer. Phosphatidylserine is strictly confined to the inner layer, facing the inside of the cell. It acts as an internal signaling molecule. It is never supposed to touch the blood plasma.
But storage damages that membrane structure.
Yes.
Yeah.
As the stored cell degrades, the membrane loses its integrity and actually flips. The phosphatidylserine that was hidden on the inside is suddenly exposed on the outside of the red blood cell.
And I'm guessing the immune and coagulation systems do not like seeing that inner lipid on the outside.
They view it as a massive alarm bell. In the flowing bloodstream, exposed phosphatidylserine is aggressively prothrombotic.
Wow.
It acts like a chemical magnet, rapidly attracting and binding circulating clotting factors. So when you take a bag of this stored, degraded blood and infuse it into a trauma patient, you aren't just giving them oxygen carriers.
You are infusing millions of damaged cells coated in a prothrombotic trigger. You are basically injecting millions of microscopic clot starters into a patient whose system is already chaotic from trauma. That perfectly explains why they can develop deep vein thrombosis, or DVT, just from a transfusion.
It is a profound paradox of modern medicine. It's a major contributor to what we call traumatic coagulopathy, where the attempt to save the patient's volume actually triggers a lethal clotting cascade.
This is the exact cellular mechanism driving the modern push for patient blood management, right? The protocol to minimize transfusions and only use them when absolutely physiologically critical, rather than just treating a lab number.
Exactly.
That is an incredible dive into the mechanics. Now, before we move on, we have to acknowledge that blood loss isn't always a dramatic arterial bleed. What about chronic blood loss? A slow-oozing gastric ulcer or heavy, prolonged menstrual cycles?
The mechanism of failure is completely different here. The blood volume never drops fast enough to cause shock or trigger the massive sympathetic panic.
The fluid loss is easily replaced by drinking water. The bone marrow simply ramps up production to replace the slow trickle of lost red blood cells.
So the factory just works a little overtime.
Right, until the raw materials run out.
The marrow compensates beautifully for months, even years. But every red blood cell that oozes out of that ulcer takes a tiny bit of iron with it. Eventually, the body's deep iron stores are completely exhausted.
The marrow wants to make cells, but it has no iron to build hemoglobin.
At that point, the chronic blood loss evolves into iron deficiency anemia.
Which is the perfect bridge to our next major category. What happens when the plumbing is intact? No leaks, acute or chronic, but the manufacturing plant itself fails. Let's go inside the bone marrow and look at the anemias of diminished erythropoiesis.
Bone marrow can fail in several distinct ways, and we categorize these failures by how they alter the morphology of the cells they produce. Let's begin with the macrocytic normochromic anemias,
also known as megaloblastic anemias. So macrocytic means the factory is making cells that are way too large. We're talking an MCV greater than 100 centiliters. The stem cells themselves, the precursors in the marrow, are huge. They are called megaloblasts.
and they mature into these giant, clumsy red blood cells called macrocytes.
Why does the factory start building giants?
It comes down to a profound disruption in the cell cycle, specifically driven by a deficiency in either vitamin B12 or folate. These two nutrients have many roles, but their most critical function in the bone marrow is facilitating DNA synthesis.
Without B12 or folate, the cell cannot synthesize DNA properly. Let me try to visualize this malfunction. Imagine the developing red blood cell is like a water balloon attached to a hose.
Yep.
The rubber balloon itself is the cell membrane, and the hose pumping water into it represents the synthesis of RNA and hemoglobin proteins.
Right.
In a healthy factory, the water pumps in, the balloon inflates to the exact right size, and then a mechanical arm pinches the balloon off, tying the knot. That pinch is cell division, driven by DNA synthesis.
That is a highly accurate conceptualization. Now introduce the B12 deficiency.
The B12 is missing, so the mechanical arm, the DNA synthesis required to trigger cell division, is broken. It stalls out. But the water hose, the RNA replication, and the hemoglobin production doesn't know the arm is broken.
It just keeps pumping at full blast.
So hemoglobin keeps pouring into the cell, but the cell can't divide to relieve the pressure. It just swells, getting bigger and bigger and bigger.
The cell nucleus is delayed, but the cytoplasm keeps expanding. The result is a massive, overinflated macrocyte. And because the hemoglobin production never stopped, the cell has a normal or even slightly elevated concentration of hemoglobin. Thus, they are normochromic.
But bigger isn't better. A giant, overinflated water balloon is incredibly fragile.
Extremely fragile. These macrocytes have structurally defective membranes. When they are finally released into the bloodstream, they can't survive the turbulence.
So they rupture and die prematurely in a process called eryptosis.
The anemia occurs not because the body can't make hemoglobin, but because these massive defective cells are dying much faster than the marrow can replace them.
The most famous and historically the most terrifying of these macrocytic anemias is pernicious anemia. It's a B12 deficiency. But for a long time, doctors were baffled because these patients were eating plenty of meat and dairy, which are full of B12, yet they were still dying of the deficiency.
Because the failure isn't in the diet, it's in the delivery system. The root cause of pernicious anemia is almost always an autoimmune attack occurring within the stomach lining.
The stomach, not the marrow.
Correct. The parietal cells in the mucosal lining of your stomach secrete an essential carrier protein called intrinsic factor.
Okay, intrinsic factor.
When you eat a steak, the vitamin B12 in the meat is released in the stomach. But B12 cannot cross the intestinal wall by itself. It absolutely requires intrinsic factor to act as its molecular escort.
So intrinsic factor binds to the B12, carries it safely all the way down to the ileum in the small intestine, and unlocks the specific receptors that allow B12 to be absorbed into the blood.
Precisely. So in pernicious anemia, the immune system mistakenly targets and destroys Those parietal cells in the stomach. No parietal cells means no intrinsic factor.
No intrinsic factor means no escort.
You could consume massive amounts of B12 orally, and it would just pass entirely through your digestive tract and end up in the toilet. The bone marrow starves while the stomach is full of vitamins.
It is a devastating disconnect. And before the discovery of injectable B12, which bypasses the gut entirely, this disease was uniformly fatal. Hence the name pernicious, meaning highly injurious, destructive, and deadly.
The onset of pernicious anemia is incredibly insidious. The clinical manifestations develop over decades.
The text notes it can take 20 to 30 years for the B12 stores in the liver to finally deplete.
By the time a patient actually feels sick enough to go to the doctor, their hemoglobin might be down to 7 or 8 grams per deciliter. They present with the profound fatigue and weakness of severe anemia, but they also present with unique, deeply troubling neurological symptoms.
Like they complain of paresthesia, a numbness, tingling, or burning sensation in their fingers and toes. They might stagger or have severe difficulty walking. Why does a blood disease cause a patient to lose their balance?
Because B12 isn't just for red blood cells. It is absolutely critical for maintaining the myelin sheath, the protective lipid insulation wrapped around your nerves, particularly in the spinal cord.
Oh, wow.
Without B12, that myelin sheath begins to chemically degrade and unravel. The nerve signals short circuit. The paresthesia and the staggering are signs of active, potentially irreversible demyelination in the spinal cord.
That is terrifying. You also see unique physical signs on the outside. Patients develop glossitis. Their tongue becomes smooth, beefy red, and incredibly sore because the rapidly dividing cells of the tongue's surface are failing to regenerate properly.
And their skin. The text describes it as a lemon yellow or sallow hue.
Why lemon yellow? Why not just pale from the anemia or deeply jaundiced from liver failure?
It is the specific intersection of two pathologies. First, you have the severe pallor from the lack of circulating red blood cells. The skin is white. Second, remember those massive fragile macrocytes constantly rupturing in the bloodstream?
Oh, right, the eryptosis.
That constant low-level eryptosis releases a steady stream of extra bilirubin into the blood, causing a mild, subtle jaundice. When you mix the stark white pallor of anemia with the faint yellow of mild bilirubin buildup, the skin takes on that distinct, pale, lemon yellow tint.
Okay, let's look at the exact opposite manufacturing error. Let's move to the macrocytic hypochromic anemias. The factory is now churning out cells that are tiny and pale, and the undisputed global heavyweight of this category is iron deficiency anemia, or IDA.
It is the most common nutritional disorder on the planet, affecting up to 20% of the global population. The mechanism here is straightforward starvation.
The red blood cell is essentially a bag designed to hold hemoglobin. Hemoglobin is built around a core of iron.
If the bone marrow does not have iron, it cannot construct the hemoglobin molecule. If there's no hemoglobin to pack inside, the cell never grows to its full size and it lacks its red pigment, small and pale.
We mentioned chronic bleeding as a major cause, but it can also be dietary or poor absorption due to something like celiac disease, or simply an overwhelming increased demand, like during pregnancy when a mother is literally building a second human circulatory system.
But what's crucial for understanding the pathology is that iron deficiency doesn't hit all at once. The factory doesn't just stop one Tuesday. It's a slow, 3-stage economic collapse.
It is a gradual depletion of reserves.
Stage I is completely silent. The body is actively depleting its deep iron stores, pulling from the ferritin bank in the liver and the bone marrow macrophages to keep the assembly line running.
If you drew their blood, their circulating iron levels and hemoglobin would look perfectly normal. The patient has no idea they are running a deficit.
Then we enter stage 2. The deep storage vaults are officially empty. The transport proteins carrying iron to the marrow suddenly have nothing to carry.
The marrow is still trying to build cells, but the supply chain is broken. This is the onset of iron-deficient erythropoiesis.
But the patient still might not feel severe symptoms because the blood is still full of the normal red blood cells that were manufactured weeks ago. It is only when we reach stage 3 that the clinical picture shatters.
Stage 3 is when the newly minted, tiny hemoglobin-deficient microcytes are finally released into the bloodstream. They gradually replace the older, healthy cells as they die off from old age.
Only now, when the blood is flooded with these defective tiny cells, does the total hemoglobin drop precipitously. This is when the fatigue and the shortness of breath finally hit.
And if the iron starvation continues long enough, we begin to see specific, fascinating structural breakdowns in the body's epithelial tissues. the tissues that line the surfaces and cavities of the body.
These tissues have very high cell turnover rates, so they are highly sensitive to a lack of oxygen and iron-dependent enzymes.
The textbook highlights a few bizarre physical signs. The nails change shape.
Yes, a condition called koilonychia. The fingernails become incredibly thin, brittle, and coarsely ridged. Eventually, they actually invert, becoming concave or spoon-shaped.
You can literally place a drop of water in the center of the nail, and it will hold it like a bowl.
You also see chylosis, which are painful cracks and fissures at the corners of the mouth, and general scumbatitis, an inflamed, sore mouth.
But the symptom that sounds genuinely miserable is the development of an esophageal web.
Patients will present complaining of dysphagia, a physical difficulty swallowing solid food. When you look inside, you find an actual web of tissue.
From the chronic iron deficiency.
Yes, it causes the mucosal tissue at the juncture of the hypopharynx and the esophagus to grow abnormally, forming a thin, concentric membrane that literally partially blocks the throat.
I want to emphasize one vital point about IDEA, specifically regarding pediatric patients. It's not just about a child being tired or having brittle nails.
The text states, unequivocally, that iron deficiency in young children is associated with irreversible cognitive impairment.
The developing brain is voracious. It requires massive amounts of iron for neurogenesis, myelination, and the synthesis of neurotransmitters.
If you starve the brain of iron during critical developmental windows, the neurological architecture is permanently altered. You cannot simply give them iron pills 5 years later and reverse the cognitive damage. It is a profound public health issue.
Let's shift to the final morphological category, normocytic normochromic anemias. In this scenario, the individual red blood cells being produced are structurally perfect.
They are the right size and packed with hemoglobin.
The problem is simply that the factory has been throttled or destroyed. The overall production volume is drastically low.
The most prevalent example here is the anemia of inflammation, historically referred to as the anemia of chronic disease. We see this mild to moderate anemia consistently in patients suffering from prolonged infections, chronic autoimmune diseases like rheumatoid arthritis or systemic cancers.
The mechanism here is a brilliant, albeit frustrating example of the immune system working exactly as it evolved to, but causing massive collateral damage in the process. It's a defensive siege strategy initiated by cytokines.
When the body detects a chronic threat, macrophages and lymphocytes flood the system with inflammatory cytokines, particularly interleukin-6 and interleukin-1 beta.
These chemical messengers travel straight to the liver and issue a command, produce a peptide hormone called hepcidin. Hepcidin is the master warden of the body's iron supply. What does hepcidin actually do when it floods the system?
Hepcidin enforces a strict systemic iron lockdown. Normally, macrophages in the spleen consume old red blood cells, extract the iron, and export it back to the bone marrow to build new cells.
Hepcidin binds to the export channels on those macrophages and violently degrades them.
The iron is trapped inside the macrophage. Furthermore, hepcidin travels to the gastrointestinal tract and shuts down iron absorption from the diet.
It's total iron sequestration. But why? Why would the immune system deliberately starve its own bone marrow of iron?
Because it's trying to starve the enemy. Bacteria and rapidly dividing cancer cells absolutely depend on circulating free iron to survive and multiply.
The immune system's logic is brutal but evolutionary sound. We have an invader. Hide all the food. Lock the iron in the vaults.
But the collateral damage is that the bone marrow is also starved. And it gets worse, because those same inflammatory cytokines travel to the kidneys and actively suppress the production of erythropoietin.
So the marrow gets absolutely no raw iron to build with, and the alarm bell telling it to build is muffled. The result is a persistent, frustrating anemia.
And it's vital to understand that giving these patients oral iron supplements often achieves absolutely nothing, because the hepcidin blockade refuses to let the intestines absorb it. You have to resolve the underlying inflammation to lift the siege.
Which brings us to the most catastrophic failure of the factory, aplastic anemia. This isn't just a throttling of production, it's the physical annihilation of the stem cells. And it doesn't just affect red blood cells, it causes pancytopenia.
Pancytopenia is the hallmark. It means a severe reduction or total absence of all three major blood cell lineages: erythrocytes, leukocytes, and thrombocytes, red cells, white cells, and platelets.
If you look at a normal bone marrow aspirate, it looks like a bustling, incredibly crowded city of vibrant, actively dividing stem cells.
But if you look at the marrow of someone with severe aplastic anemia, that vibrant city has turned into a desolate ghost town. The stem cells have been wiped off the map, and the empty space is just filled in with passive fat cells. The marrow is termed hypocellular.
What drops the bomb on this city?
In approximately 75% of cases, the trigger is idiopathic, meaning the initial inciting event is unknown. However, we do know the mechanism of destruction. It is an aggressive immune-mediated assault.
The patient's own cytotoxic T cells fundamentally misidentify the hematopoietic stem cells as foreign invaders. The T cells infiltrate the marrow and systematically execute the stem cells.
The remaining cases are secondary, triggered by known toxic exposures like massive ionizing radiation, industrial chemicals like benzene, or certain potent chemotherapeutic drugs that inadvertently wipe out the marrow.
We also see rare inherited forms like Fanconi anemia, where a genetic defect in DNA repair causes the stem cells to spontaneously exhaust themselves early in life.
Regardless of whether it's an autoimmune attack or chemical destruction, the clinical reality is terrifying. The patient isn't just dealing with the hypoxia of anemia.
Because they have no white blood cells, a common cold can rapidly evolve into fatal sepsis.
Because they have no platelets, a minor bump can cause uncontrollable internal hemorrhage. Survival depends on intense immunosuppression or a complete bone marrow transplant to rebuild the city from scratch.
All right, we've covered what happens when the blood leaks out and what happens when the factory fails to make it. Let's pivot to the fourth mechanism. What if the bone marrow is churning out millions of perfectly healthy red blood cells, but they are being violently murdered the second they enter the bloodstream?
These are the hemolytic anemias. Hemolysis is the premature, accelerated destruction of erythrocytes.
This destruction can occur in two distinct arenas, right?
Yes. Extravascular hemolysis takes place outside the main blood flow, primarily inside the spleen and liver, where resident macrophages literally hunt down and consume the red blood cells.
And intravascular hemolysis is much more violent. It occurs directly within the flowing blood vessels, where the cells are physically sheared apart or blown open by chemical attacks.
Let's focus on the acquired immune-mediated forms, specifically autoimmune hemolytic anemias. This is when the immune system goes rogue and produces autoantibodies that specifically target the patient's own healthy red blood cells.
The clinical presentation is heavily dictated by the optimal temperature at which these rogue antibodies operate. We have warm reactive and cold hemolysin.
Warm autoimmune hemolytic anemia is the most frequently encountered. It is driven predominantly by immunoglobulin G, or IgG, autoantibodies. These IgG antibodies are highly active and bind optimally to the red blood cell surface at normal core body temperature, 98.6 degrees Fahrenheit.
So the antibody attaches to the cell. It doesn't instantly destroy it, right? It just tags it.
Exactly. It's a biological tracking device. The IgG coats the red blood cell. As this tagged cell circulates, it eventually passes through the tight, twisting corridors of the spleen.
The spleen is packed with macrophages whose specific job is to look for IgG tags. The macrophage identifies the tag, latches on, and consumes the red blood cell through phagocytosis.
This is classic extravascular hemolysis. The cells are being quietly eaten in the spleen. But cold hemolysin, also known as proximal cold hemoglobinuria, is a completely different, much more dramatic beast.
This often occurs in pediatric patients shortly after a standard viral infection like the mumps or measles.
The mechanics here are startling. In this condition, the rogue autoantibodies, usually IgM, only bind to the red blood cells when the blood cools down, typically when it circulates through the exposed capillaries of the fingers, toes, or ears on a cold day.
Okay, so the antibody attaches in the cold extremities, but the destruction doesn't happen there.
No. The destruction is unleashed when that cold, tagged blood returns to the warmer core of the body. The sudden shift in temperature activates the complement cascade.
Complement is a series of potent immune proteins that assemble into attack complexes. These complexes literally punch physical pores holes directly through the red blood cell membrane.
So the cell violently bursts wide open while it's still inside the blood vessel. Massive intravascular hemolysis. Millions of cells detonate simultaneously, dumping their raw, uncontained hemoglobin directly into the blood plasma.
This free hemoglobin is quickly filtered by the kidneys and dumped into the urine, turning the child's urine a terrifying, dark, reddish-brown color almost instantly.
That is horrifying for a parent to see. Now, it's not always a random autoimmune glitch. Sometimes modern medicine triggers the crossfire. Let's walk through the 3 models of drug-induced hemolytic anemia. This is crucial for anyone administering medications.
Medications can inadvertently turn red blood cells into targets in 3 distinct ways. The first is the Hapten model, and high-dose intravenous penicillin is the classic culprit.
A Hapten is a tiny molecule that is invisible to the immune system until it physically binds to a larger carrier protein. In this model, the penicillin drug molecule forcefully binds directly to the outer surface proteins of the red blood cell.
So the drug is literally stuck to the outside of the cell.
Yes.
Yeah.
And the immune system, patrolling the blood, spots this bizarre drug-protein combination. It correctly identifies the drug as foreign and generates IgG antibodies against the penicillin.
The antibodies attack the drug, but because the drug is cemented to the red blood cell, the entire cell is dragged down and phagocytized by a macrophage. The red blood cell is just an innocent bystander that got a target painted on its back.
The second pathway is immune complex formation, often triggered by drugs like quinidine. This one is a bit more chaotic. Here, the drug doesn't bind to the cell. The drug binds to a random carrier protein floating freely in the blood plasma.
The immune system generates an antibody against this floating drug protein unit, creating an immune complex, a tightly bound cluster of antibody and drug.
So you have these microscopic clusters floating like landmines in the blood. And by sheer physical chance, these floating immune complexes bump into a red blood cell.
They happen to stick to a specific receptor on the cell surface called C3b. Once attached, the immune complex activates the complement cascade right there on the cell surface.
The complement punches a hole in the cell, destroying it. The red blood cell did absolutely nothing wrong. It was just in the wrong place at the wrong time when the complex snagged it.
And the third mechanism is the autoimmune model, associated with drugs like methyldopa. This is arguably the most insidious because the drug doesn't even have to be present when the destruction happens.
In this model, the drug fundamentally alters the immune system's tolerance. The drug somehow induces the body to generate autoantibodies that have absolutely zero affinity for the drug itself.
Instead, these antibodies are perfectly designed to attack the normal intrinsic Rh antigens that naturally exist on every healthy red blood cell the patient has. The drug simply flipped a switch in the immune system, turning it permanently against the self.
So if a patient is experiencing massive hemolysis, whether from a cold virus or a drug reaction, what is the clinical picture?
The hallmark is profound, rapid onset jaundice. Remember, every bursting red blood cell releases massive amounts of Hesway, which degrades into bilirubin.
The liver is a powerful organ, but it has a processing limit. When hemolysis is explosive, the sheer volume of bilirubin utterly overwhelms the liver's conjugation pathways.
The bilirubin backs up into the blood and aggressively stains the skin, the mucous membranes, and the sclera a deep yellow. You would also likely feel an enormously enlarged spleen, splenomegaly, because those macrophages are gorging themselves on millions of tagged cells, causing the organ to swell with activity.
Now, physiological question. If millions of cells are being destroyed, the kidneys must be screaming for more oxygen. Why doesn't the bone marrow just crank up production to replace them? How fast can the factory actually run?
A healthy bone marrow is astonishingly resilient. In the face of severe hemolytic destruction, the marrow can massively expand its production lines. It can push erythrocyte production to an incredible 6 to 8 times its normal resting rate.
8 times normal capacity.
Yeah.
So the marrow is just churning out millions of reticulocytes, immature red cells every hour to keep the patient alive.
It's a heroic physiological effort, but it creates a fragile tightrope. The patient's survival is utterly dependent on the marrow maintaining that 8x overdrive.
If a healthy person catches a mild parvovirus, the virus might suppress red cell production for 2 or 3 days. You wouldn't even notice. But if our hemolytic patient catches that same parvovirus and their marrow production halts for just 48 hours, they suffer an aplastic crisis.
Because the destruction is still happening at light speed, but the replacement suddenly stops.
Exactly. Their red blood cell count plummets catastrophically in a matter of hours, leading to profound shock and death if not transfused immediately.
Okay, take a breath. We have spent an enormous amount of time analyzing the many, many ways the body can find itself with too few red blood cells. It's time to flip the script entirely.
Let's explore the pathology of overproduction. What happens when the body makes way too many?
This brings us to the myeloproliferative disorders, specifically the condition known as absolute primary polycythemia, or polycythemia vera, PV. To be clear, we are not talking about a dehydrated marathon runner whose blood is temporarily concentrated because they sweat out all their plasma.
PV is a chronic, slow-growing blood cancer. In PV, the bone marrow is neoplastic and wildly hyperplastic. It is relentlessly churning out massive, overwhelming quantities of red blood cells and usually extra white cells and platelets as well.
And the terrifying part is that this production is entirely independent of erythropoietin. The kidneys are not asking for more blood. The oxygen levels are fine, but the factory is running at 300% capacity anyway.
What drives this madness?
The root cause is a microscopic genetic error. More than 95% of individuals diagnosed with PV harbor an acquired genetic mutation in a specific gene called JAK2.
To grasp why this single mutation is so devastating, we have to look at how a stem cell normally decides to divide. Let's trace the signal.
Normally, the kidney releases erythropoietin into the blood. That EPO molecule floats into the marrow and binds to a specific receptor on the outer surface of a stem cell.
Attached to the inside of that receptor is a protein called JK2. JK2 is a tyrosine kinase. Think of it as a biological light switch.
When EPO binds the receptor, it flips the JK2 switch on. JK2 then sends a chemical signal deep into the cell nucleus, commanding the cell to divide and mature into a red blood cell.
Crucially, a healthy JK2 protein is self-regulating. It quickly flips itself back off once the signal is sent, but the JK2 mutation fundamentally breaks the switch.
Yes, the mutated JK2 kinase loses its regulatory domain. It is physically jammed in the on position.
It relentlessly fires division signals into the nucleus 24 hours a day, regardless of whether erythropoietin is present at the receptor or not. It completely bypasses all physiological control mechanisms.
And the physical consequences of this runaway cellular proliferation are severe. Earlier, we used the analogy of anemia turning thick syrup into watery, turbulent blood. Polycythemia vera does the exact devastating opposite. It turns the blood into sludge.
We call it hyperviscosity. The massive, unnatural accumulation of red cell mass creates a thick, sticky, sluggish fluid that genuinely struggles to push its way through the microscopic capillary beds.
It's like trying to pump wet cement through the vascular system.
And that sluggish, stagnant flow creates a severe, systemic, hypercoagulable state. The platelets are bumping into each other, the flow is slow, and clots form spontaneously.
The ultimate threat to a PV patient isn't the cancer spreading. It is thrombotic occlusion. It is a massive blood clot suddenly blocking a critical vessel, causing tissue ischemia and infarction.
The risk of death from cerebral thrombosis, a massive stroke, is 5 times greater in individuals with unmanaged polycythemia vera. You can physically see this sluggish, engorged system just by looking at the patient.
The sheer volume of red blood cells causes plethora, a deep, ruddy, flushed red coloration of the face, hands, feet, and mucous membranes. If an ophthalmologist looks into their eyes, the retinal veins are physically swollen and engorged with thick blood.
The same is happening in the brain, which causes severe headaches, visual disturbances, and a constant, heavy drowsiness. And there's one hallmark symptom that is agonizingly unique to PV acrogenic pruritus.
Intense itching caused by water.
Yes, patients experience severe, painful, burning itching across their body that is triggered simply by their skin coming into contact with water, regardless of the water's temperature. Stepping into a shower becomes an excruciating experience.
We believe this is related to the massive numbers of abnormal mast cells and basophils produced by the mutated marrow accumulating in the skin and releasing histamine and inflammatory mediators in response to the osmotic change of the water.
Before we leave the red blood cells entirely, I want to briefly touch on a different kind of excess. Not too many cells, but too much of the raw material. Let's look at iron overload, specifically hereditary hemochromatosis.
This ties beautifully back to our discussion of hepcidin, the master iron warden. Hereditary hemochromatosis is an autosomal recessive genetic disorder characterized by mutations, most commonly in the HFE gene.
These mutations critically disrupt the body's ability to synthesize or respond to hepcidin.
So if hepcidin is the warden that normally locks the gates and tells the intestines to stop absorbing iron from our food, what happens when the warden is missing?
The gates are left wide open. The gastrointestinal tract continuously absorbs massive amounts of iron from the diet, day after day, year after year, completely unchecked by the body's actual iron needs.
But the human body doesn't really have a physiological mechanism to excrete excess iron, right? We can't pee it out.
Correct. We only lose tiny amounts through shedding skin cells or bleeding. So this massive daily influx of iron simply pools in the blood.
When the transport proteins are completely saturated, the toxic free iron starts forcing its way into the tissues of the major organs for storage.
It aggressively infiltrates the liver, the pancreas, the heart muscle, and the skin. In the early stages, the patient might just feel vague, chronic fatigue and arthralgia, which is severe joint pain as the iron damages the synovial lining.
But as the decades pass and the iron load reaches massive toxic levels,
The tissue destruction becomes irreversible, the liver becomes fibrotic, leading to cirrhosis and liver failure. The iron destroys the beta cells in the pancreas, causing diabetes mellitus.
the heart muscle becomes stiff and fails, and the massive iron deposits in the skin react with melanin to cause a distinct unnatural bronze or grayish pigmentation. It is a slow, silent poisoning by an essential nutrient.
Wow. Okay, we have thoroughly mapped the pathology of the oxygen carriers. It is time to pivot our attention. We are moving from the body's transport system to the body's defense force.
Let's delve into the alterations of leukocyte function, the white blood cells. When we evaluate white blood cells on a complete blood count, a CBC, we are primarily looking for quantitative shifts.
Is the absolute number of circulating defenders too high or is it too low? These shifts are powerful early indicators of what the immune system is battling.
Let's define the extremes. Leukocytosis means the total white blood cell count is higher than normal. Leukopenia means the count is abnormally low. But functionally and clinically, these two states are not equal in their significance.
Not at all. Leukocytosis is very frequently a perfectly normal, healthy physiological response to a stressor. If a patient is fighting off a localized bacterial pneumonia, or they just underwent major surgery, or even if they're in the third trimester of a normal pregnancy, their white count will naturally rise.
The body is successfully mobilizing its reserves to handle the stress. It's the system working as intended.
But leukopenia, a low white count, is never normal. It is never a healthy physiological adaptation. The text firmly defines it as an absolute count of less than 4,000 cells per microliter.
And the real terror sets in when that drop specifically impacts the neutrophils. Neutrophils are the frontline infantry. They are the primary phagocytes responsible for engaging and destroying bacterial invaders.
If a patient's absolute neutrophil count, the ANC, plummets below 500 cells per microliter, a state called severe neutropenia, they are effectively defenseless.
The patient is at an immediate life-threatening risk for overwhelming opportunistic infections. A normal, benign skin flora can suddenly become a fatal systemic sepsis.
Let's linger on the neutrophils for a moment because they provide us with one of the most ubiquitous and historically fascinating clinical terms used in hematology.
You will hear nurses and doctors say this on the floor constantly. The patient's CBC shows a left shift, or they have a shift to the left. What is actually physically happening to the blood cells to warrant that term?
It's a beautiful intersection of biological panic and textbook formatting. When a patient contracts a severe, overwhelming systemic infection, the demand for frontline neutrophils is staggering.
The circulating neutrophils are quickly consumed in the battle.
To keep fighting, the bone marrow desperately starts prematurely ejecting immature, unready neutrophils directly into the bloodstream. These immature cells are called bands, or myeloblasts.
So the marrow is drafting teenagers because it ran out of adult soldiers. But why is it called a shift to the left?
Because of how early hematologists drew diagrams of cellular maturation. In almost every medical textbook, the lineage of a white blood cell is drawn horizontally across the page.
The most primitive, undifferentiated stem cells are drawn on the far left side of the page. Arrows point to the right as the cells go through their maturation stages, ending with the fully mature, multi-lobed neutrophil on the far right.
So when a lab technician looks at a patient's blood smear under a microscope and sees a massive influx of these primitive band cells, the overall demographic of the population has literally shifted toward the left side of that textbook diagram.
A shift to the left is simply visual shorthand, indicating that the bone marrow is frantically dumping immature reserves into the circulation because the mature forces are losing the war.
I love when clinical slang has a literal, physical origin like that. Now, the CBC also tracks the specialized white blood cells. An increase in these specific subsets acts like a biological fingerprint, telling us exactly what kind of threat the body is reacting to.
Yes. For example, consider eosinophilia, an absolute increase in circulating eosinophils. Eosinophils are highly specialized for two distinct scenarios.
The first is an acute allergic disorder, like a severe asthma attack or anaphylaxis. The second is a parasitic infection, like a helminth worm.
How does the marrow know to specifically deploy eosinophils instead of neutrophils?
Chemical signaling. When mast cells in the tissue detect an allergen or a parasite, they release a specific cytokine called interleukin-5. IL-5 travels directly to the marrow and acts as a highly specific summons, commanding the rapid proliferation and release of eosinophils to the site of the attack.
Then we have basophils. Basophilia is quite rare.
Very rare. Basophils are essentially circulating packets of histamine and heparin. They are heavily involved in immediate hypersensitivity reactions and orchestrating severe inflammatory responses.
Interestingly, if you see an unexplained, persistently high basophil count, you must consider the possibility of a myeloproliferative disorder, like the polycythemia vera we discussed earlier.
Monocytes are an interesting group. A high monocyte count, monocytosis, usually shows up late in the timeline of an infection. Why the delay?
Because monocytes are the heavy-duty cleanup crew. When they leave the blood and enter the tissues, they transform into massive macrophages.
We typically see monocytosis in the late stages of the recovery phase of a severe bacterial infection. The neutrophils have done the killing, and now the macrophages are called in to phagocytize the surviving microorganisms and clear out the massive amounts of cellular debris and dead tissue left over for the battle.
Finally, we have the lymphocytes, the highly advanced B cells and T cells. If you see lymphocytosis, a massive spike in lymphocytes, you are almost never looking at a bacterial threat.
Lymphocytes are the primary defense against viruses. Acute viral infections, most famously the Epstein-Barr virus, which causes infectious mononucleosis, provoke a massive proliferation of antigen-specific lymphocytes.
So all of those shifts, the left shift, the eosinophilia, are examples of the white blood cells behaving correctly, multiplying to face an external threat. But what happens when the white blood cells themselves lose their genetic minds and become the threat?
This brings us to the malignancies of the marrow, specifically the leukemias. Leukemia is a devastating primary disruption of the bone marrow. It is fundamentally a cancer of the blood-forming organs. The defining characteristic is the uncontrolled, relentless proliferation of malignant, highly dysfunctional leukocytes.
The intuitive thought is that if you have millions of extra white blood cells, you must have an incredible immune system. But the clinical reality is the exact opposite.
Because those millions of cells are malignant clones. They are immature, wildly dysfunctional blasts that are completely useless for fighting infection. But their uselessness isn't what kills the patient, it's their sheer physical mass.
The domino effect of the crowding.
Yes. The leukemic cells multiply recklessly inside the bone marrow cavity. The physical space inside the core of a bone is finite, cannot expand. As the clone army multiplies, it physically crushes and crowds out all the normal, healthy hematopoietic stem cells.
So even though leukemia is technically a cancer of the white blood cells, the patient actually presents with pancytopenia. The cancer suffocates all three cell lines. Let's trace how that physical crowding directly creates the textbook symptoms.
It is a direct cause and effect. The malignant blasts physically crowd out the normal erythroblasts. The factory stops making red blood cells. The result: profound anemia, severe fatigue, and pallor.
Next, the blasts crowd out the megakaryocytes, so the factory stops making platelets.
The result: severe thrombocytopenia. The patient develops petechiae pinpoint hemorrhages under the skin ecchymosis or large bruises from zero trauma, and eventually uncontrollable spontaneous internal bleeding.
And finally, the blasts crowd out the few remaining normal myoblasts, so the patient stops making healthy, functional neutrophils.
The result is severe neutropenia. The patient is flooded with useless cancer cells, but has absolutely zero functional immune defense, leading to overwhelming, often fatal opportunistic infections.
There is also an agonizing physical symptom caused directly by this cellular crowding: severe, unrelenting bone pain. The malignant mass is literally expanding outward, putting massive pressure on the highly innervated periosteum, the membrane lining the inside of the bone.
Now, to understand why these cells are proliferating so recklessly, we have to look at the genetics. And the textbook highlights perhaps the most famous genetic anomaly in all of oncology: the Philadelphia chromosome.
It is a landmark discovery in molecular biology. The Philadelphia chromosome is the defining genetic hallmark of chronic myelogenous leukemia, or CML, though we do see it in some acute leukemias as well. It is the result of a reciprocal translocation between chromosome 9 and chromosome 22.
Let's visualize that violence. A chromosome physically breaks in half.
Yes. A piece of the long arm of chromosome 9 breaks off entirely. Simultaneously, a piece of chromosome 22 breaks off. And then the cell's repair machinery makes a catastrophic error. It swaps them, it glues the piece of 9 onto 22, and the piece of 22 onto 9.
And the danger isn't just that the pieces are in the wrong place. The danger is exactly where they were glued together.
Exactly. The break on chromosome 22 happens right in the middle of a gene region called BCR. The piece coming over from chromosome 9 contains a powerful proto-oncogene called ABL1.
When they are spliced together on the new shortened chromosome 22, the Philadelphia chromosome, they fuse to create a brand new mutant gene, BCR-ABL1.
And what biological instruction does that mutant gene give the cell?
It is a blueprint for destruction. The BCR-ABL1 gene codes for a novel mutant protein that acts as a hyperactive tyrosine kinase.
Very similar to the JNK2 mutation we discussed, this mutant protein is a switch permanently glued in the on position.
It relentlessly drives intracellular pathways that force the cell to proliferate uncontrollably. Furthermore, it actively blocks the apoptosis, the programmed cell death pathway, meaning these cancer cells never die, they just multiply forever.
But knowing the exact molecular structure of that mutant switch allowed scientists to build an incredible weapon against it. The text discusses a targeted therapy that absolutely revolutionized CML treatment.
Yes, the drug imatinib, famously known as Gleevec. It is a masterpiece of rational drug design. Imatinib is a tyrosine kinase inhibitor.
Molecular biologists mapped the exact three-dimensional shape of that mutant BCR-ABL1 protein. They found its active site, the ATP binding pocket. They then designed the imatinib molecule to physically fit perfectly into that specific pocket, like a key into a lock.
By plugging that pocket, the drug physically blocks the mutant protein from transferring its energy. It completely silences the relentless division signal. The cancer cell stops dividing and eventually dies.
It turned a uniformly fatal leukemia into a manageable chronic condition just by turning off one specific broken switch.
It represents the holy grail of oncology, hitting the cancer at its precise genetic root without destroying the healthy cells around it. Now, we just discussed CML, which requires us to differentiate between the acute and chronic forms of leukemia.
Right. Acute leukemias, like all in children or AML in adults, are explosive. They involve highly undifferentiated, completely immature blast cells that multiply at astonishing rates. The clinical onset is abrupt, stormy, and rapidly fatal within months if untreated.
Chronic leukemias operate on a different timeline. Chronic leukemias like CLL and CML involve cells that are further along in the maturation pathway. They look more like mature cells, but they are deeply dysfunctional.
Chronic lymphocytic leukemia, CLL, primarily involves the malignant transformation of mature B lymphocytes. These clones accumulate slowly. They look like normal B cells under a microscope, but they are immunologically incompetent. They fail to produce the functional antibodies the body needs.
The text also notes a unique epidemiological quirk about CLL. It has a surprisingly high familial association compared to almost all other leukemias. If a first-degree relative has CLL, your risk is significantly elevated.
Yes, genetics play a heavy role there. Let's move to our final malignancy of the marrow. It also involves B cells, but a very specific, fully mature type. We are looking at plasma cell malignancy, explicitly multiple myeloma, or MM.
A plasma cell is the final ultimate form of a B cell. Its sole dedicated purpose in life is to be a massive factory pumping out specific antibodies to fight infection. So what happens when one of those factories goes malignant?
In multiple myeloma, a single malignant plasma cell undergoes massive clonal expansion within the bone marrow. You have millions of identical cancerous plasma cells, and because their intrinsic nature is to produce antibodies, this massive clone army relentlessly pumps out massive quantities of one identical, completely defective antibody.
The textbook refers to this defective product as an M protein or a paraprotein.
This M protein floods the blood, becoming the most prominent protein in the patient's plasma. But it's worse than just being useless. The sheer mass of this malignant clone actively suppresses the surrounding normal plasma cells.
The patient's production of healthy, diverse antibodies plummets. They become incredibly vulnerable to recurrent infections, particularly from encapsulated bacteria like Streptococcus pneumonia, because they have no functional humoral immunity left.
But the M protein doesn't just sit there. It is actively destructive, particularly to the kidneys. And it's not just the whole antibody. The myeloma cells often produce broken fragments of the antibody.
Yes. The malignant cells are often uncoordinated in their manufacturing. They produce excessive amounts of the light chains, the smaller protein arms of the antibody, without attaching them to the heavy chains. These unattached fragments are called free light chains, or Bence-Jones proteins.
And their size is the problem.
Exactly. Because Bence-Jones proteins are relatively small, they easily pass through the glomerulus, the initial filter in the kidney. But as they travel through the renal tubules, they are highly toxic to the tubular epithelial cells.
They damage the cells, form massive protein casts that physically block the tubes and relentlessly destroy the kidney from the inside out, leading directly to acute or chronic renal failure.
And the destruction isn't limited to the kidneys. Multiple myeloma is notorious for devastating the skeletal system. The malignant plasma cells secrete a cocktail of inflammatory cytokines like IL-6 and rank ligand that powerfully stimulate osteoclasts.
Osteoclasts are the cells that naturally break down and resorb bone tissue. The myeloma cells hyperactivate them.
The osteoclasts begin aggressively dissolving the bone matrix right where the tumor is sitting. This creates massive, punched-out olytic bone lesions, leading to excruciating bone pain and severe pathologic fractures bones, snapping from simply walking or rolling over in bed.
And when you rapidly dissolve that much solid bone, all the calcium stored inside it has to go somewhere.
It floods the bloodstream, causing severe hypercalcemia. High blood calcium leads to neurological confusion, lethargy, muscle weakness, and further damages the failing kidneys.
On top of the renal failure, the fractures, and the calcium overload, the sheer volume of that massive M protein circulating in the plasma actually thickens the blood, leading to hyperviscosity syndrome, just like we saw in polycythemia vera, impairing blood flow to the brain.
And there is one final bizarre systemic complication of MM mentioned in the text: amyloidosis.
Amyloidosis is a terrifying protein folding disorder. In some myeloma patients, those free light chains, those Bence-Jones proteins, misfold and stick together. They form incredibly rigid, insoluble protein sheets called amyloid fibrils.
These sheets precipitate out of the blood and permanently deposit themselves inside the tissues of major organs.
But just encase the organs in rigid protein.
Yes. They deposit in the peripheral nerves, causing severe painful neuropathy. They deposit in the heart muscle, making it stiff and causing restrictive heart failure. They even deposit heavily in the tongue, causing macrocytic. The tongue becomes so massively enlarged and stiffened by protein that the patient cannot close their mouth or swallow.
The sheer multi-organ destructive cascade triggered by the malfunction of one single plasma cell is staggering. Kidneys, bones, heart, nerves, all destroyed by defective proteins. Now, all of these rogue cells and toxic proteins circulate continuously, but eventually they have to pass through the body's primary blood filter. Let's transition our focus to the abdomen. Let's look at the alterations of splenic function.
The spleen is an incredibly active, densely vascularized lymphoid organ. It performs several critical roles, but the two most relevant to our pathophysiological discussion are its role as a massive filter for phagocytizing old, damaged, or antibody-coated blood cells, and its role as a holding tank, a site for sequestering formed blood elements.
When assessing a patient, we have to make a very sharp clinical distinction between splenomegaly and hypersplenism. They sound similar, but functionally, they are very different.
Splenomegaly simply means the spleen is physically enlarged. It can swell due to infection, liver cirrhosis causing portal hypertension, or because it's infiltrated by leukemic cells. A spleen can be massively enlarged, but still function perfectly normally.
Hypersplenism, however, means the spleen has become wildly overactive. Its normal physiological functions have shifted into a pathological overdrive.
It stops being a gentle filter and becomes a massive, inescapable trap.
Exactly. An overactive spleen begins aggressively sequestering perfectly healthy red blood cells, white blood cells, and platelets. It pulls them out of circulation and hoards them in the splenic pulp.
The textbook notes that a severe hypersplenic state can sequester and hold up to 50% of the body's entire red blood cell population at any given moment.
Half of your oxygen carriers are just trapped, sitting idle in the filter.
And because the spleen is packed with hungry macrophages, this massive pooling exposes all those trapped healthy cells to premature phagocytosis. The spleen starts eating the healthy cells it trapped.
The systemic result of this massive sequestration and destruction is, once again, pancytopenia. The blood tests show low red cells, low white cells, and low platelets, not because the marrow isn't making them, but because the spleen is hoarding and destroying them.
This physical enlargement creates unique mechanical symptoms for the patient. The spleen sits tucked up in the upper left quadrant of the abdomen, right next to and slightly behind the stomach.
When it swells from its normal size of a small fist to the size of a football, it runs out of room.
It physically presses inward, putting massive mechanical pressure on the stomach wall. This is why patients with severe splenomegaly frequently report vague, persistent abdominal discomfort and early satiety. They sit down to eat, take 3 or 4 bites, and feel completely stuffed because their stomach physically cannot expand. The spleen is crushing it.
And there is a fascinating systemic exacerbation here, the dilutional effect. The spleen has trapped half the red blood cells, so the body's overall oxygen delivery drops.
The cardiovascular system senses this drop and reacts exactly as we discussed earlier. It pulls water into the blood vessels to increase volume and maintain pressure.
It's a vicious, self-defeating cycle. The extra fluid further dilutes the already reduced concentration of blood cells that actually manage to escape the splenic trap, making the anemia clinically much more severe.
That aggressive pathological sequestering of platelets by the overactive spleen leads us directly into our final and perhaps most complex topic of the chapter. We are moving to the mechanisms of hemostasis, hemorrhagic disorders, and alterations of platelets and coagulation. We're looking at how the body patches leaks and why it sometimes builds concrete walls inside the vessels when it shouldn't.
Let's begin with the cellular component of the clot, platelet disorders. Platelets, or thrombocytes, are the sticky fragments that form the initial physical plug over any vascular breach.
The baseline definition of thrombocytopenia is a platelet count falling below 150,000 per microliter of blood. But the textbook points out that patients don't usually show clinical signs of bleeding right at 149,000.
No, the system has massive redundancy. You generally don't see prolonged bleeding from routine minor trauma until the count drops below 50,000. But when the count plummets below 10,000 to 15,000, the patient enters a state of critical peril.
At that level, you see spontaneous bleeding. The microscopic daily wear and tear on the capillaries can no longer be patched.
The patient develops widespread petechiae, large purpuric spots, and is at massive risk for spontaneous, fatal gastrointestinal or intracranial hemorrhage without ever suffering a trauma.
There are dozens of acquired causes for low platelets, but the text highlights one specific iatrogenic meaning caused by medical treatment, that is a stunning biological paradox. I'm talking about HIT, heparin-induced thrombocytopenia.
It is one of the most dangerous and complex complications encountered in a hospital setting.
The paradox is what stops students dead in their tracks. Heparin is a powerful anticoagulant that's a blood thinner. We explicitly administer it to patients to prevent them from forming clots.
Yet the condition is called heparin-induced thrombocytopenia. How does a drug designed to thin the blood simultaneously destroy platelets and cause massive lethal blood clots?
It is a catastrophic immunological misfire. Let's trace the molecular steps. In some susceptible patients, when you administer heparin, the heparin molecule bumps into a normal, stabilizing protein that sits on the outer surface of platelets. This protein is called platelet factor 4, or PF4. The heparin binds tightly to the PF4.
Okay, so the drug sticks to the platelet.
Yes, and the patient's immune system looks at this new combined heparin PF4 complex and completely misidentifies it as a dangerous foreign antigen. The immune system reacts by rapidly generating an IgG autoantibody, specifically designed to target that complex.
So the antibody hunts down the platelet and binds to the complex. Does it destroy the platelet immediately?
No, the destruction is secondary. This is where the paradox happens. The tail end of that IgG antibody, the FFC portion, physically reaches over and binds to a specific FC receptor on the surface of the platelet. When that receptor is engaged, it acts as a massive violent activation signal. It's like throwing a physiological grenade into the platelet.
The platelet is violently activated.
Exactly. The platelet instantly releases massive amounts of procoagulant microparticles and rapidly begins aggregating, clumping together with thousands of other activated platelets.
So you suddenly have thousands of platelets forming massive aggressive clots inside the major blood vessels. That explains the extreme prothrombotic state.
These patients develop massive deep vein thrombosis, pulmonary embolisms, and severe arterial thrombosis that can cause strokes or necessitate limb amputations.
And why is the platelet count low? Because this massive systemic inappropriate clotting physically consumes the body's entire supply of circulating platelets. They're all being rapidly used up to build these deadly clots. Thus, the terrifying paradox. The patient is dying of massive, widespread thrombosis, but their lab reports show profound thrombocytopenia.
That is fascinating and horrifying. Now, let's contrast HIT with ITP, immune thrombocytopenic purpura. This is a much more straightforward mechanism of autoimmune destruction.
It is the classic model. In ITP, the immune system simply generates autoantibodies, usually IgG, that bind directly to normal, healthy platelet glycoproteins. There is no drug trigger required.
The antibody coats the platelet, acting as a tag. The tag platelet floats through the spleen. The splenic macrophages recognize the IgG tag and phagocytize the platelet.
The text notes that acute ITP is most often seen in children following a standard viral infection. The immune system gets temporarily confused by the virus, starts destroying platelets, but usually resolves itself spontaneously within a few months as the immune system calms down.
Chronic ITP is more common in adults and can require splenectomy to physically remove the site of destruction. But if we want to talk about complex mechanical platelet destruction, we have to examine TTP, thrombotic thrombocytopenic purpura.
This one is an absolute beast. The textbook refers to it as a microvessel disease, and it provides a beautiful, intricate explanation of the molecular mechanism. It all hinges on a single vital enzyme that goes missing, ADAM-MTS13.
To understand the pathology of TTP, we first have to understand the normal architecture of a clot. The endothelial cells that perfectly line the inside of your blood vessels secrete a massive, sticky protein called von Willebrand factor, or VWF.
Its job is to act as the primary glue to catch platelets when a vessel is damaged.
The text describes VWF as being secreted in these ultra-large, incredibly long multimeric strings that anchor to the vessel wall and trail out into the flowing blood.
Think of them as giant, ultra-sticky spider webs or fishing nets drifting in the current.
Normally, if these giant nets were left alone, they would catch too many platelets and block the vessel. So the body deploys a regulator, the ADAM-TS13 enzyme.
The molecular scissors?
Precisely. ADAM-TS13 is a protease. It floats along in the plasma, specifically looking for these ultra-large von Willebrand strings. When it finds one, it snips it. It cleaves the massive string into much smaller, perfectly safe pieces that can help form a normal clot without blocking the entire vessel.
But in a patient with TTP, they are profoundly deficient in ADAM-TS13. Usually they have developed an autoantibody that completely neutralizes or destroys the scissors. So the scissors are gone.
Which means those ultra-large, giant sticky nets of von Willebrand factor are never snipped. They remain fully anchored to the capillary walls. As the blood flows past, normal, healthy platelets get caught in the giant nets. The physical catching activates them, and they begin to clump.
Very quickly, you have massive, rock-hard platelet clumps, physically occluding the tiny arterioles and capillaries throughout the body, particularly in the brain and kidneys.
The consumption of the platelets in these nets causes the profound thrombocytopenia. But TTP has another defining hallmark, microangiopathic hemolytic anemia. The anemia isn't caused by the immune system eating the red cells. It's caused by sheer mechanical violence.
Imagine the physical dynamics. You have a microscopic capillary that is now 90% blocked by this massive, rigid clump of von Willebrand factor and activated platelets. Behind it, the heart is still pumping, creating massive arterial blood pressure. The red blood cells are forcefully rammed into this microscopic barricade.
They are forced through the tiny remaining gaps under high pressure.
It's like pushing a delicate water balloon through a cheese grater. The sheer physical force slices the red blood cell apart. It is mechanically sheared in half. The resulting jagged, torn fragments of the red blood cells are pushed out the other side.
These fragmented cells are called schistocytes.
So if a lab tech looks at a blood smear and sees a low platelet count accompanied by dozens of these torn, jagged schistocytes, the diagnosis of TTP is practically confirmed. It is a terrifying mechanical destruction of the blood, and it is a medical emergency requiring rapid plasma exchange to physically remove the autoantibodies and replenish the ADAM-TS13 scissors.
Briefly, we must also acknowledge the inverse quantitative problem, thrombocythemia, specifically essential thrombocythemia, ET. This is when the platelet count skyrockets over 450,000, sometimes exceeding 1 million.
This is classified as a myeloproliferative neoplasm, and it's often driven by the exact same mutated JAK2 switch we saw causing polycythemia vera. But in this case, the switch is relentlessly commanding the stem cells to overproduce megakaryocytes, the giant precursor cells that splinter apart to form platelets.
The clinical danger is similar to PV, severe microvascular thrombosis, millions of extra sticky platelets spontaneously clumping and blocking tiny vessels. And this leads to a unique, incredibly painful hallmark symptom of ET called erythromelalgia.
Erythromelalgia. The text describes it as warm, congested, intensely red hands and feet, accompanied by a painful burning sensation.
Because the microscopic arterioles feeding the fingers and toes are physically plugged with platelet sludge. The blood backs up, the tissue becomes inflamed and hypoxic, and the patient experiences a severe burning agony in their extremities.
Okay, we have covered the cellular plug, the platelets. Now we need to look at the protein cascade that pours the concrete to hold that plug together. Coagulation disorders. The intricate cascade of clotting factors weaving a tough fibrin mesh, and almost all roads in this cascade lead directly to a single organ, the liver.
The liver is the undisputed master factory of hemostasis. The hepatic parenchyma cells synthesize almost every single clotting factor required for the coagulation cascade factors 2, 7, 9, X, B11, and fibrinogen. Furthermore, the liver produces the essential regulatory proteins that prevent clotting, like antithrombin and protein C, and it produces the plasminogen needed to break clots down once the tissue is healed.
The analogy I use is that the liver is the body's exclusive supplier of repair cement. If that single factory shuts down, whether from viral hepatitis attacking the cells or chronic alcohol abuse leading to fibrotic cirrhosis, the body loses its ability to patch even the tiniest microscopic leaks.
And the decline is predictable. The textbook notes that factor 7 is typically the first coagulation factor to drop to dangerous levels during liver failure. This is because factor 7 has the shortest half-life of all the factors. It degrades quickly in the blood, so it requires constant minute-by-minute replacement by the liver. When the liver stalls, factor 7 vanishes almost immediately, drastically prolonging the prothrombin time, PT.
But liver failure doesn't just deprive the body of clotting factors, it also sabotages the platelets.
Yes. The liver synthesizes thrombopoietin, TPO, the primary hormone that stimulates the bone marrow to produce platelets. Failing liver means plummeting TPO, leading to thrombocytopenia. Furthermore, the liver manufactures our molecular scissors, 8-MTs13.
So a patient in end-stage liver failure is facing a complete hemostatic collapse. They have no factors to build the fibrin mesh, they have no platelets to form the initial plug, and because they lack 8-MTS13, whatever platelets they do have might clump abnormally. The entire balancing act of the blood is destroyed. Every minor bump or gastric erosion becomes a massive, potentially fatal hemorrhagic crisis.
Which perfectly sets the stage for the most complex, paradoxical, and uniformly terrifying coagulation disorder described in the textbook. DIC, disseminated intravascular coagulation. The text provides intricate flowcharts in figures 29.32 and 29.33, but the reality of DIC is a chaotic, systemic storm.
The most important thing to grasp about DIC is that it is never a primary disease. A patient doesn't just spontaneously catch DIC. It is always a secondary complication triggered by a massive catastrophic underlying crisis, severe multi-trauma, overwhelming gram-negative sepsis, widely metastatic cancer, or severe obstetric emergencies like placental abruption.
These massive crises all share one common pathophysiological feature. They cause widespread systemic damage to the endothelial cells lining the blood vessels, or they trigger a massive systemic inflammatory response. This widespread damage exposes a potent chemical called tissue factor directly to the circulating blood.
And tissue factor is the match that lights the coagulation fire.
It is the primary initiator of the extrinsic clotting cascade. Normally, tissue factor is safely hidden underneath the endothelial lining, only exposed when there is a physical cut. But in sepsis or trauma, massive amounts of tissue factor are exposed system-wide all at once. This triggers an explosive, unchecked systemic activation of the entire coagulation cascade.
The body goes into hyperclotting overdrive. It begins rapidly constructing thousands and thousands of microthrombi, tiny, tough fibrin clots inside small and mid-sized vessels all over the body.
This widespread microvascular thrombosis is devastating. The tiny clots physically block blood flow to the major organs, leading to widespread ischemic tissue necrosis, rapidly causing acute kidney failure, pulmonary failure, and brain damage. And just like we saw in TTP, these thousands of tiny clots act like cheese graters in the vessels, mechanically shearing the red blood cells as they squeeze past, producing massive numbers of schistocytes.
But the hyperclotting is only the first phase of the nightmare. Here is the fatal paradox of DIC. Because the coagulation system is indiscriminately building millions of microclots everywhere simultaneously, it completely and rapidly consumes all of the body's available platelets and clotting factors. It uses up all the cement on these tiny, useless clots.
It is a massive consumptive coagulopathy. The body completely depletes its reserves of fibrinogen, platelets, and every major clotting factor.
So you have a patient whose major organs are actively dying because they are choked with thousands of clots. But because they have absolutely zero clotting factors left in their plasma, they simultaneously begin to hemorrhage uncontrollably. They bleed profusely from every IV insertion site, from their mucosal membranes, from their surgical wounds, into their brain and GI tract.
It is the ultimate physiological nightmare. The condition is often grimly described by clinicians as clotting so much that you bleed to death. It is incredibly difficult to manage. You are fighting massive, organ-destroying thrombosis and massive exsanguinating hemorrhage at the exact same moment. You cannot simply give them massive doses of heparin because they're bleeding to death.
You cannot simply flood them with clotting factors because it just adds fuel to the thrombotic fire.
You have to desperately support their hemodynamics while aggressively treating the underlying trigger, the sepsis or the trauma, hoping the liver can eventually catch up and restore balance.
To close out the coagulation chapter, the text briefly contrasts the mechanics of arterial versus venous thromboembolic disorders, just the spontaneous formation of clots in different parts of the plumbing.
It comes down to fluid dynamics. Arterial thrombi form under conditions of high blood flow and high pressure. Because the blood is rushing past so quickly, only the stickiest components can hold on to a damaged vessel wall. Therefore, arterial clots are composed almost entirely of tightly packed platelet aggregates held together by thin strands of fibrin. They are white clots.
Venous thrombi, on the other hand, like a classic deep vein thrombosis in the leg, form in low-flow, sluggish conditions.
Yes. Because the venous flow is slow and pooling, massive amounts of red blood cells get physically trapped in the sprawling fibrin mesh as it slowly forms. Venous clots are bulky, gelatinous red clots, heavily loaded with trapped erythrocytes alongside the platelets. Understanding the structural difference dictates the medical treatment. Antiplatelet drugs like aspirin for arterial risks and anticoagulants like heparin or warfarin for venous risks.
Wow, we made it. From the deepest microscopic cavities of the bone marrow to the smallest peripheral capillaries in the toes.
It is an astonishingly complex, flawlessly interconnected system when it works, and a terrifying cascade when it breaks.
So let's look back at our roadmap and summarize what we've discovered. What we've seen today is the incredible, fragile interconnectedness of the hematologic system. We've seen how a single microscopic genetic switch jammed in the on position, a GAK2 mutation, can literally turn the blood into sludge. We've seen how the lack of a single carrier protein in the stomach lining can lead to the physical degeneration of the spinal cord. We've seen how the immune system's attempt to starve a bacterial invader of iron can result in starving the bone marrow instead.
And through it all, it comes back to our core philosophy. You cannot treat the symptom until you intimately understand the cellular failure that caused it.
Which brings me to a final provocative thought for you to mull over as you continue your studies. Throughout this deep dive, we've constantly looked at the body's desperate attempts to compensate. The heart racing to pump watery blood, the liver locking down iron, the bone marrow frantically dumping immature white cells to fight an infection. These aren't random errors or chaotic glitches. They are deep, evolutionary survival pathways carved out over millions of years of human history to protect us from bleeding out on the savannah or dying of sepsis from a simple cut.
They are ancient, hardwired defense mechanisms.
Exactly. But now we practice modern, high-tech medicine. We keep people alive with massive trauma transfusions, complex artificial valves, and powerful targeted molecular drugs that our evolutionary biology never, ever anticipated. So here is the question to leave you with as you walk the hospital floors. As you look at your critically ill patients, how much of their pathophysiology is the disease itself, and how much is their ancient evolutionary programming reacting violently to our modern medical interventions? What happens when our desperate attempts to save the system end up triggering the very ancient pathways that tear it apart?
A profound and necessary question to keep in the front of your mind as you learn to intervene in these delicate systems.
Indeed. Thank you for joining us for this extensive deep dive into Chapter 29. Keep studying, keep asking why the mechanisms work the way they do, and we will see you next time. A very warm thank you from the Last Minute Lecture team.